Lights out.
Welcome everybody once again to another fantastic episode of SleepTech Talk, the sleep podcast. For all you folks out there, sleep techs, sleep docs, sleep whatever, we're here for you with your friends and hosts, Emerson Kerr, Robert Miller, and me, still trying to figure out what I do here, Dr. Gerald George Moneycorrode. And we have one absolute fantastic guest once again for you guys today. And I'm going to have Emerson talk to you a little bit about that. Emerson.
All right. Thanks, Jerry. Well, we're really happy to have Massey Arrington on with us from WellStar Sleep Centers in Atlanta, Georgia. Massey is a registered polysomnographic technologist like the rest of us, also a registered sleep tech, and a certified clinical health sleep educator. And so Massey is the executive director over 12, count them, 12 WellStar Sleep Centers in Metro Atlanta, a registered sleep tech since 1993. We'll have to ask him what his number is. Massey has 30 years of both technical and leadership experience in sleep. He received his undergraduate degree in management at Tulane and his MBA in healthcare finance from Vanderbilt. So he's got us beat out on the Ivy League stuff here. So he has served in the past on the Sleep and Respiratory Committee for the American Academy of Sleep Medicine, and more for the past 2 years was chair of the AST Standards and Guidelines Committee. I received his 2021 AST Leadership Award and now serves as the director at large for the AST board. So Massey, welcome. Thanks for joining us today. One of the things that we love to ask any of our guests is how you got here, because none of us really intended to be in sleep that have been on the call so far, and oftentimes it's instructive. So Massey, how did you get into sleep?
So it's a funny story and it's a long one, but I'll keep it very short. I think my father, who is a sleep specialist as well, physician, I think he and I got interested in sleep disorders medicine at the same time. I was, I think, 9 years old, and he woke up with a bloody nose with me standing over him. I had broken his nose. I was sleepwalking. I promised I was asleep, and I loved my father dearly, but was sleepwalking, had punched him in the face. He woke up shaking me. I was obviously still in slow wave sleep, standing over him, freaking out. How did I get here? Why is my father bleeding? And he went on to become he was board certified in pulmonary and critical care. He became board certified in sleep, trained at Stanford and at UAB in Birmingham. And he, years later, when I was about to graduate from Tulane, I was actually going to be a pharmaceutical sales rep. And at the last minute, this was Upjohn. I guess I think I can legally say that. But anyway, the job went away because there was some questions about the medication that I was supposed to be repping. So literally 2 hours before graduating, I was told, yeah, we're not hiring you anymore. And so I was like, oh, what am I going to do? And my father was like, hey, man, you seem to really like this sleep stuff. We could use a good sleep tech. Why don't you come do this and learn about this until you figure out what you want to do with your life? And a couple months into it, learning all the engineering aspects, and I was really enamored with how we see little squiggly lines and convert electrical energy into what we can read on the paper. And I loved it, and I stuck with it, and still doing it. So that's how I got started. That's the short version.
That's a great story, Massey. I just wanted to work 3 nights a week. It was pretty short, and I think I was going to make 50 cents more than I made working in an operating room. So I hear you. But Massey, I told you earlier before we even started the podcast today that I think you have a topic that is going to be very, very important to our listening audience. And by the way, for our listening audience, be sure that you are liking, that you're sharing the podcast. Make sure that you do a review so that we get lots of interest from the podcast gods. And we want to make sure that we can continue to do this, and we appreciate your support through all of it. But Massey, back to the critical topic for today. We really wanted to cover your inpatient program and your sleep navigator program that you have at your hospital system, because you've been able to deploy it in a very successful way. And I love it that you have the data points to even back up how successful the program is. And so we'd love for you to share, how your program is, how it works, maybe some of the pitfalls so that you can help, other folks who want to implement a similar program in their hospital system. But please share with us about your inpatient sleep program.
Great. Yeah, thanks. And trying to figure out how to screen inpatients is something most of us have probably considered for a long time. Different things throughout my career we tried to do unsuccessfully. And when I got to WellStar, and I had this conversation with my medical director, Dr. Hitendra Patel, about kind of this vision, because when I got here, they had a sleep navigator that was a nurse. And that person was helping with really with outpatient medical group physician visits, getting them, making sure they were being referred, the orders, troubleshooting with doctors who didn't know how to complete an order or what to document. But we had this idea, that there was this large patient population that was sick and coming into the hospital and then getting readmitted due to problems that were being exacerbated by sleep disorders. And I won't lie, I did a lot of research, specifically Andrea Ramberg, who's now the president of the BRPT. I researched her paper, looked at some stuff that was coming out from some of the other hospitals and how they'd started screening some specific subgroups. And at WellStar, the idea was the prerequisite to having a sleep disorder is, do you sleep? And the prerequisite for sleeping is, are you a human or are you a mammal? Every mammal sleeps, and you have the potential for having a sleeping problem. So we didn't want to just target the low-hanging fruit, COPD or stroke. We wanted to make sure that everybody had the opportunity to be screened for a sleep disorder, sleep apnea specifically with the stop bang. And I was really grandiose, and I went to the CNO and I was like, let's do this everywhere. And they were like, oh, hold on there, buddy. These CCSH sleep navigators are not cheap. They're well educated. They're hard to find, at least when we first started talking about this in 2017. Put together a plan, put together a pilot, do it at one hospital in our system, and let's see its success. And then we'll start talking about growing it. And let me make sure nobody wants to stop and ask me a question. Okay, good. So we did it at one hospital, and the flow is really, there were some challenges. Like on the front end, we had to get nursing buy-in. We had to make sure that everybody was comfortable with the CCSHs. All of us have NPIs, that we were given the appropriate permissions to do the documentation that we needed to do in Epic, and to have that documentation reviewed by an attending or a hospitalist and signed off on. So we trialed it at one of our smaller hospitals, Douglas Hospital, and probably I'd say, yeah, definitely one of our smaller hospitals, nowhere near like the size of Kennestone, maybe 250 beds, give or take. And in the first 12 months, they saw 17,000 inpatients roughly were screened. And of that, about 23% had a positive stop bang. And when those patients, the way it works, yeah, go ahead. Mm-hmm.
Did you say 17,000?
17,000, yeah. So for 1 year at one hospital, 17,000 total admissions. So we don't screen like I've heard other programs, and I'm not criticizing them. Any screening is great, but there are some programs where they just screen in if you've had a stroke or if you've had an MI or a COPD. We screen every admission. Now, the ER patients, we don't screen them while they're actively in the ER. They don't get screened until they get admitted and are stable. If you come in with a gunshot wound to the chest, we're not, do you snore? But
hey, Massey, one question. Once a patient screens positive, is there an identifier for that patient, like an arm bracelet or something in the electronic medical record that would identify them as a high-risk sleep apnea patient?
Yes. So what it is, everybody gets the stop bang, and then the nurse, and it's usually an RN or a CNA, whoever the nurse is, does it really quick. And the cool thing about Epic and other EMRs is if they're already an established patient, most of the questions are already, they pull from the data. So we already know your gender. We already know your BMI. Really, it comes down to, do you snore? Are you tired? And do you know your neck circumference? But the entire stop bang is asked to every admission. If the data is not automatically pulled, that if it's positive, and at Douglas for the first year, we used a 5 or higher. We didn't use a 4 or a 3. We wanted to make sure that we were addressing the people who had the highest likelihood of untreated sleep apnea. That goes into a workflow, automatically notifying our navigator. Our navigator then starts their day off by opening up Epic going, I had 3 admissions last night, 2 admissions I didn't get to yesterday that are still here because they probably came in after the end of the workday. And they start their day by going to see the patients, and they go and visit each patient. They do a complete education workup. It's a template. It's in Epic, where they document talking about the patient snoring or their sleep patterns, high risk indicators. They review the need for sleep testing and how it could potentially be making worse their problem or connected to their admission, if it is a connection. In some cases, though, I mean, we get people who are in a car accident and break their leg, truck driver or whatever, and they come in and they're obese and they flag. We talk to them as well. And once that education piece is done and documented in Epic, they can actually pen an order saying we think this patient needs a home sleep apnea test if they don't have multiple comorbidities, or if it's a severe patient, we think this patient needs a split night. They actually prepare kind of a pended order with everything they've covered. That then goes to the hospitalist or the attending doctor, and it will pop up on their screen, yes, no, opportunity to adjust, whatever the doctor needs to do. Doctor approves the order. That order then goes into a work queue for those patients to get their authorization and get scheduled. And we typically schedule them after discharge to come in, usually about 4 days after discharge. We give them an opportunity to stabilize. And then if they don't want to have a study, and some patients don't, they're like, oh, I just getting out of the hospital. Let me go talk to the doctor. They'll get a consultation scheduled. But that piece is also automatic in the EMR.
So, Massey, one question for you. One of the things I've always thought about a sleep navigator's role that could be extremely important, instead of doing sort of generic sleep apnea education, do condition-specific sleep apnea education. So you tie their admitting condition to, their sleep apnea, so that they understand specifically how, whatever their issue is could be exacerbating their sleep apnea or vice versa. But is it condition-specific education today, or is it just a little more general, and then helping the patient understand the post-discharge process?
Yeah, so it's condition-specific when the condition applies. But if it's a brand new, like if they're admitted for something completely unrelated to sleep, but they happen to have flagged for a high scoring stop bang, it's kind of a general. The sleep navigator goes in and kind of gets a feel for other health issues. The COPD, MI, stroke, and what's the one I missed? CHF. Those are condition specific, and a huge amount of education and detail goes into making that connection. And with how the sleep disorder or the potential sleep disorder could be making their CHF or COPD worse, and treatment options and other things we can do that would help them prevent from being readmitted and improve their overall health and well-being. When it's not condition specific, it's a general education. So the sleep navigators, they all have to be CCSHs. We created the job description, that we made that a requirement, and as part of that, they know which approach to use, because there's also different patients who learn in different ways. Some people are visual, some people are auditory, some people need to digest, some people need to ask a lot of questions. Our navigators spend approximately 20 to 30 minutes with each of these patients documenting the education that's taking place in their chart, and that becomes part of their permanent record.
So I've got lots of questions. I apologize. I'm the one who's taken up all the questions today. But so a couple of things. What would be a typical day as far as the number of patients that one of your sleep navigators, how many patients can they see in a day? But then also, could you share some of the successes as it relates to the increases in volume for the sleep center? Because that really ultimately, it is a great program for the patient. Obviously, that's what we're all here for, is the patient care aspect. But, at the end of the day, we, as an industry, we've struggled to grow our sleep programs, and this is exactly the way that you do it. So do you mind sharing some of the success stories that you have?
No, not at all. It's been very successful. And of course, the initial reason is to prevent readmissions, right? And that's why a lot of hospitals only focus on those that will give you the readmission penalty, and those are usually the worst. WellStar's vision is to improve the health and well-being of every patient, so there was a big push. Let's just screen everybody. So we did that, and we thought it's a big chew. But as I mentioned earlier, out of the 17,000, we had about 22% of those patients ended up being positive for stop bangs. We saw every one of them, and at the end of the day, I was expecting probably a 0.9 of all admissions, 0.9%, pull-through rate to either a consult or a sleep study. I looked at both, right, because they're both a win. That both means the patient's either getting seen by a sleep specialist and then either having the appropriate study or testing, but if not necessary, that's fine. We still help the patient. We're actually ended up after a year and a half now, we're seeing about a 4.3% pull-through rate. So we're very busy, and that has generated a dramatic, as a secondary benefit, a dramatic increase in our total attended volume and our home sleep apnea testing, and really in the total number of patients who are being treated. But the kicker, Robert, before I tell you about a typical day, is our first 12 months at Douglas, we only had 8 patients get readmitted. Unfortunately, 2 of them passed away. Those 8 patients didn't get tested. They declined the consultation. But that was 8 out of the 23% of 17,000. I don't have the number in front of me, but it was a Six Sigma type of level. It was a very low readmission rate. When we compared that to the readmission rate of the hospital in general prior to the navigator, the readmission rate was much higher. So there is a significant savings, especially on the patients that when you get readmitted, it's free, COPD, MI, stroke. But that was very compelling. I was expecting the readmit, I knew we were going to help reduce readmissions, but we helped a lot more than I thought we would. A typical day, depending on the volume, because you can't predict it, anywhere from 6 on the low end, 6 patients to see, to 16 or 17 patients to see. They spend about 20, 30 minutes seeing each of these patients. They also have a couple of other job duties. They interact with patients and do physicians and do physician education. They attend all of the different readmission council meetings, CHF readmission, COPD. There's different task forces groups associated. They're on that. They're also community diplomats for us. They go out and we do as many talks. One of them just did a talk at a local library. I know that another one went to a senior assisted living center and did a talk on sleep. So they're also educating the community in their quote unquote spare time. And they're just very busy, and they're very well paid. I won't lie. The salary is very competitive, and it's a good living, and it's well earned. But the thing that's really important if I put my finance cap on, is the net increase in direct margin, the net revenue, collected revenue, is very positive. I can't give specific numbers. WellStar would get mad at me, but they're not only paying for themselves,
Yep.
but we're seeing about a 7.8 to 8.5% growth year over year just on attended studies, and about a 22% year over year growth in home testing volume. I don't have the pulmonary consultation, the sleep consultation data, but if our business is going up that much, I can imagine so is theirs. That's a lot of people helped. So I'll pause now for questions.
Massey, it's probably one of the most impressive and most sophisticated inpatient sleep navigator programs that at least I'm aware of. I know that Andrea and Christina Weaver have certainly done great jobs with the programs that they ran, and there's a lot of data, and I hope you're collecting a lot of information, because you have a very important story to tell, because ultimately you're also creating a lower cost of care patient, post-treatment, as long as they're adherent to therapy. And then I love it that you are including this as part of, and that your team's part of the post-discharge and readmission reduction group, because ultimately that would be the end game as well, would be to take a high-risk patient and ensure through it. I always use the example of a patient who's on a BiPAP device. We get respiratory rate, minute ventilation, tidal volume, adherence to therapy, and if the therapy is effective, data every single day for a patient who had not, maybe they had not been diagnosed and treated while they were in the hospital. That's a patient that's going to exacerbate and end up right back in the hospital again.
Right,
So,
and they're much more challenging to intubate. They're much more challenging. I mean, it's hard, and it's important work. And we came at this really with the philosophy that sleep should be a vital sign. Every time you see anybody, they're checking your blood pressure, they're checking your weight, they're checking some other vital statistics. Sleep in some way, shape, or fashion, be it a stop bang, an Epworth, I don't really care, but that discussion needs to take place. And in our case, specifically, the stop bang has been the most effective. And we're just right now, I'm only doing it at 3, although I have 12 centers. We have 13 hospitals, I think, and 4 health parks. I want every hospital to have a navigator, and we're budgeting for it. We're planning to roll it out to 2 more hospitals next fiscal year, and they're 2 big ones, doozies, Kennestone and Cobb.
Massey, this has been absolutely amazing and eye-opening. Like Robert said, there's just so much. First off, it overall community, from a community health standpoint, it makes a tremendous difference. But also, as Robert was saying, when you look at the other aspects of it, how well it helps the entire health system from an economical standpoint, as you pointed out, from whether it's an individual employment or from the finances as the health system, it makes a tremendous difference. But we're about to running out of time now. Is there anything else that you want to just highlight before we close?
No, I'm very proud of my team. I'm proud of my medical director, Dr. Hitendra Patel. I would be remiss if I didn't talk about the engagement with Dr. Gay at the Mayo Clinic, where there were a lot of people looking at this and a lot of people came together and a lot of time. And it took years. I've been at WellStar 5 years. We officially rolled this out 1.5 years ago, and I've been working on it since my 2nd week. So we've come a long way. WellStar is a fantastic team to work for, and you guys have been wonderful. Thank you for letting me join you today. Maybe I can come back sometime, talk to you another year, see how we've done.
We would love to hear that. It would be great to hear a follow-up and hear more of these numbers that you brought up. For us, we're all on the business side, so we get it, and it'd be very interesting to hear that as well. But with that, we want to say thank you also for joining us. It was a fantastic discussion. And to all our viewers out there on YouTube and those listeners on the various platforms, thank you so much for your support. We sincerely appreciate you joining us and listening to us each and every week. And we ask you to don't forget to hit the thumbs up button, to like and add your comments or whatnot, and just go out and spread the word. But thank you all so much. Take care. Until next time, see you later. Lights on.